Welcome to this symposium on maximizing outcomes for patients with device therapy. We've put together an excellent symposium of 3 different topics. My name is Martin Cowie. I'm Professor of Cardiology at Imperial College in London. It's a great pleasure to co-chair this with Professor Cecilia Lind from the Karolinska Institute in Stockholm. So the 3 topics we're covering are ICD therapy, initially, cardiac resynchronization therapy, and also the use of left ventricular assist device technology. The first speaker is Dr. Miner from Utrecht in the Netherlands, who will be updating us on how best to use ICD technology to reduce the risk of sudden cardiac death, patient selection, the clever algorithms that can be used now to try and minimize inappropriate shocks. We'll have question and answers after that. Please use the chat function, and we'll try and get through as many of those questions as we can before Professor Witte from Leeds will talk to us about cardiac resynchronization therapy, recent guidelines, patient selection, how to optimize this technology. There'll be a period of questions and answer, and then a final talk by Dr. Tots from Leiden in the Netherlands, talking about left ventricular assist device technology, patient selection, when these devices should be used, and also the central role of the LVAD team in optimizing patient outcomes. At the end of that, Professor Lind will take over and give us some concluding remarks. So please do relax and enjoy these excellent presentations. Thank you.
Good afternoon, everybody. My name is Matthias Miner. I am cardiologist, electrophysiologist at the University Medical Center in Utrecht in the Netherlands. Our group is specialized in preventing and treatment of sudden cardiac death in heart failure patients. And I am very glad to get the opportunity to discuss the efficacy of ICD therapy in modern heart failure patients while limiting side effects. First of all, let's have a look at the risk of sudden cardiac death in the heart failure studies of the last 25 years. It seems that sudden cardiac death rate may decrease by modern pharmacological treatment of heart failure, but this trend is mainly driven by the old studies RAILS, BEST, and MERIT-HF. In these former heart failure studies, patients were not implanted with an ICD for primary prophylactic reasons, and in the Paradigm HF, 15% of the patients were already protected by an ICD. In the RAIL study, patients with functional class of heart failure 3 or 4 were included, whereas in the Paradigm HF, 75% were functional class 1 and 2, and we know that the event rate in asymptomatic and in patients with mild symptoms of heart failure is low. In the RAIL study, only 10% were treated with a beta blocker, whereas 93% of the Paradigm HF patients got a beta blocker. The effect of beta blocker on sudden cardiac death is very clearly shown in the MERIT-HF and CBS2 trial. You see an enormous reduction of the sudden cardiac death rate by adding a beta blocker to the heart failure medication. When comparing the Paradigm HF with the SCATHEF trial, the risk of sudden cardiac death still remains the same. In the recently published EU CERT study, it was shown that primary prophylactic ICD therapy significantly reduced mortality in European heart failure patients. This was mainly driven by reduction of sudden cardiac death rate in the ICD group. The Swedish Heart Failure Registry showed also a significant reduction of mortality by ICD therapy. They included more than 16,000 heart failure patients with a primary prophylactic ICD indication. Remarkable is that in the registry only in 10% of the heart failure patient an ICD was implanted. 13,000 ICD patients were compared to 13,000 matched non-ICD patients. Patients with an ICD had a significant lower probability of death than the matched non-ICD patients. One reason for the reserved use of ICDs may be the possible side effects of ICD therapy, especially the unnecessary shocks. So in my presentation, I want to focus on shock reduction. We already know that the majority of unnecessary ICD shocks were delivered in patients with atrial fibrillation and fast ventricular response, and when you are using ICD therapy for hemodynamically stable slow VTs. Modern electrophysiological techniques should be used to treat AF and hemodynamic stable VTs. Furthermore, smart ICD programming with longer detection intervals, SVT discrimination, and ATP for the treatment of fast VTs are tools which we have in our own hands to reduce ICD shocks. The first study that showed a 50% shock reduction by prolonging the detection duration with 30 out of 40 intervals was the PREPARE study. Not only inappropriate shocks were reduced, but also appropriate shocks because of spontaneous termination of ventricular tachyarrhythmias as shown in the figure on the right-hand side. If the NID was programmed to 18 out of 24, ATP would be delivered already after 5.5 seconds. Due to longer detection with 30 out of 40, VT was not treated because of its spontaneous termination after 27 beats. The first multicenter randomized controlled trial that showed shock reduction by prolonged detection was the ADVANCED 3 study. All ICD patients with primary or secondary prophylactic ICD indication, single, dual chamber ICD or CRTD were included. All ICDs were programmed with one VF zone above 188 beats per minute and ATP during charging was turned on. Randomization was in two groups with short detection, 18 out of 24, and long detection, 30 out of 40 NIDs. In the long detection group, less ATP and shocks were delivered. On the left-hand side, you see the cumulative probability of first ICD therapy, solid line 18 out of 24, and dotted line 30 out of 40 NID. The probability for first-time inappropriate shock was also significantly lower in the long detection group, is shown in the graph on the right-hand side, dotted line, long detection. The sub-analysis of more than 450 fast VTs showed that prolonging the detection duration reduced unnecessary ICD therapy by 39%, and in combination with ATP during charging, the shock rate was further reduced by 52%. When we are talking about shock reduction in ICD therapy, we also have to mention the Madrid study, but I don't want to go further into detail because I think that this study does not reflect the modern heart failure population because only patients with a primary prophylactic ICD indication were included, only dual chamber ICDs or CRTDs could be implanted, and patients with permanent atrial fibrillation were excluded. Furthermore, in the short detection arm, arm A, only stability and onset was used in the VT zone. Morphology discrimination was switched off, and VT-SVT discrimination was not available in the VF zone. The pain-free SST study represented a modern heart failure population. All types of ICD, single, dual chamber, and CRTDs could be implanted. All heart failure patients with a primary and secondary ICD indication or ICD replacement with or without AF could be included. Patients with a secondary prophylactic ICD indication were randomized in short detection and long detection group. Long detection with 30 out of 40 intervals was programmed in all patients in the primary prevention arm. Smart shock algorithm was programmed on in all ICDs. These two graphs show the incidence of inappropriate ICD therapy. Black line, inappropriate shocks, and blue line, any inappropriate ICD therapy in ICDs with single chamber detection, left-hand side, and dual chamber detection, right-hand side. Interestingly, the probability of inappropriate ICD therapy was much lower in the pain-free SST study compared to the Madrid study. The mean follow-up of the Madrid study was 1.4 years, and the inappropriate ICD therapy rate was 5.3%. The very low inappropriate shock rate in the pain-free SST study is becoming more clear by comparing with other ICD studies with a mean annual inappropriate shock rate of about 6.4%. The importance of programming a long detection duration was clearly shown by a meta-analysis of their studies that showed not only a significant decrease of the inappropriate shock rate, left-hand side, but also a significant reduction in mortality, right-hand side. Recently, the Swiss group published their 4P study, a prospective study on predictive quality with preferencing pain-free ATP therapies. 196 real-world ICD patients with primary or secondary ICD indication and replacement were included. The EFSON was programmed with a long detection duration, and ATP during charging was switched on. During a follow-up of 2.3 years, you see the filtering, the selection of episodes. 65% were non-sustained episodes or detected in the monitor zone. In 10% of the episodes, ICD therapy was withheld because of oversensing, SVT discrimination, or self-termination. Only 25% of the detected episodes were treated by the ICD with a 100% success rate. 95% were successfully terminated by ATP and 5% by a shock. In only 2.6% of the patients, the shock was inappropriately during 2.3 years follow-up. And that is less than in other studies published. In conclusion, the risk of sudden cardiac death remains high unless new pharmacological treatment of heart failure and can be prevented by ICD therapy. New ICD technology and ICD programming, longer detection, ATP during charging, VT-SVT discrimination, and so on, reduce significantly both the number of unnecessary ICD therapy and mortality. Recently published real-life data shows a still high number of ventricular tachyarrhythmias in ICD patients with a 100% success rate of ICD therapy, 95% ATP and only 5% shock therapy. I think that modern pharmacological treatment of heart failure in combination with modern ICD therapy can save life and improve quality of life by limiting side effects. Thank you for listening. If there are any questions, I will be happy to answer these.
Thank you very much, Matthias, for a very interesting talk and very encouraging for physicians and patients that the rate of inappropriate shocks is now down. Is it 1% per year in appropriately programmed devices? Is that the current standard?
In primary prophylactic ICD therapy, I think so. In secondary prophylactic ICD therapy, the ATP and also the shock rate may be a little bit higher.
Well, I think that's a really important piece of information for our viewers, because many heart failure physicians are reluctant to recommend ICD therapy because of this conception of so many inappropriate shocks. But obviously the field has moved on. Is that reflected in the guidelines, heart failure or EP guidelines, this improvement in shock rate?
So, as I remember, not yet. So the current ICD and also the current heart failure guidelines do not recommend the programming of ICD therapy. But I think in the upcoming guidelines, it may be good to make some suggestions for programming long detection intervals, to use discrimination for noise and ventricular tachyarrhythmias, supraventricular tachyarrhythmias. And I think it's very important to talk to your patients, to your referring physicians, that ICD therapy is safe and the inappropriate shock rate is very, very low in nowadays ICD devices.
Yeah, thank you, Matthias. And I think that's a really important point when it comes to shared decision making. And I'd like to bring in Professor Lind from the Karolinska here. In Sweden, there seems to be a relatively low rate of ICD implants. Do you think that will change as people understand that the downsides are much less and the benefits in appropriate patients might be greater with current technologies? I'm not sure that Cecilia can hear us. So we'll ask you, Matthias, looking across Europe, there's huge variation in implant rates of ICD and CRT technology. Do you think wider knowledge about what the best can be will change that across Europe?
So I hope so, but it's very inhomogeneous in Europe. You know, in Western Europe, there are more ICD implanting than in Eastern Europe, for example. There are countries with a high implant rate per 100,000 inhabitants, and there are low implant rate countries. So I think when we are following the current guidelines in whole Europe, so we have to implant much more ICDs than we do at this time.
Thank you, Matthias. A question from one of our viewers, and you didn't specifically mention this, but what's your opinion on the CRTP, CRTD discussion, which occupies a lot of time for heart failure physicians? Do you think this should encourage us more towards the CRTD rather than just CRTP, or not really?
Thank you very much. It's a very good question. So studies showed, for example, the sub-analysis from the MADIT CRT study, that when you have a super responder on CRT and the ejection fraction is above 50%, then you have to switch off ICD therapy, because then the rate of inappropriate shocks are higher than appropriate shocks, for example. But it's hard to say and to prospect, did we get a super responder or not? So I think what I see in our country and also in Europe is that more patients with non-ischemic cardiomyopathy are implanting an CRTP, and patients with an ischemic cardiomyopathy were implanting an CRTD.
Thank you. And another question is coming in about medical therapy, and you showed that beautiful graph in the New England Journal showing the rate of sudden death that is dropping, presumably because of better diagnosis, much better drug therapy, and all of the life-saving drug therapies impact sudden death. How do you think this is affecting the equation about timing of device therapy implantation for a patient? Should we be waiting 3 months, or is that old-fashioned approach?
Perhaps we have to wait a little bit longer. So when you have the first diagnosis of heart failure, then you have to start medication, and you need more than 3 months for optimal medical treatment, and to wait, is there a response on medical treatment and improving left ventricular function. So I think that beta blocker, ACE inhibitors, or other new medication are very important, but the current studies are also shown that the risk of sudden cardiac death, especially in patients with not severe heart failure, but in patients with functional class heart failure too, the risk of sudden cardiac death still remains very high, and ICD can protect our patients for sudden cardiac death.
Indeed. And in terms of working between VT, EP type programs and the heart failure team, what for you is a model that works well? People are asking, should the device just be looked after by the implanter, or should it be heart failure or crosstalk? What's your own model in Utrecht?
So I'm electrophysiologist, but I'm very close to our heart failure specialist, working together with them. And I think it's a good collaboration. And a team, there must be a technician, a heart failure specialist, and electrophysiologist. So when I have my outpatient clinic, so I'm more a heart failure doctor than electrophysiologist at this moment.
Yes, that sounds a good approach. And a technical question from a viewer. With this reduction in shock therapy, but more ATP, what impact does that have for battery life and time to replacement?
Battery life, so I don't think that this is an issue nowadays. So the battery life of ICDs are around 8 to 12 years. And a shock does not decrease battery life so much as 10 or 20 years ago. So I think the battery life is not the issue. And I think when we are effectiveness, because the old analyses were performed with battery life of 5 years, but now it's double.
Super. So Matthias, in the last 30 seconds of our question time, what would be the key take home you'd like our viewers to go away with about modern ICD technology?
Use ICD therapy in heart failure patients to prevent sudden cardiac death, and use all the features, inclusive long detection interval, to avoid unnecessary ICD therapy. Thank you so much.
Thank you very much. Really key and very important for patients as well as for healthcare professionals. So thank you very much, Matthias. And now we're going to move on to CRT therapy and patient selection. And Professor Klaus Witte, thank you so much.
Thank you.
Hello, everybody. My name is Klaus Witte. I'm a cardiologist in Leeds, and it's a delight to participate in this educational program around device therapy in heart failure. Now, we all know cardiac resynchronization therapy is a very powerful treatment for patients with heart failure due to reduced ejection fraction. It improves walk distance, reduces hospitalizations due to heart failure, and improves mortality in patients with heart failure and reduced ejection fraction and conduction delay. We also know that it can slow down progression. So in patients with mild symptoms but important reduced ejection fraction, it delays the progression of the syndrome and thereby reduces hospitalization and mortality, as we saw in reverse. After 20 years, the case surely for CRT is already made, but are there other questions that still remain to be answered? Well, let's have a look at some of the things that are still outstanding. The biggest question, I think, the big elephant in the room is, do we always need a defibrillator with a CRT device? And it's simply unbelievable that this question is still out there. Early data, now 15 years old from Companion, suggest perhaps a marginal benefit of CRTD over CRTP. Of course, the study was underpowered. It was done before the advent of widespread beta blockade in patients with reduced ejection fraction. And so we can't really base our decisions on the Companion study. There have been subsequent pieces of work done and an IPD meta-analysis, including 12,000 patients and 13 trials, does suggest that CRTD is associated with the lowest overall mortality. It suggests, as we know, that the greatest reductions with CRT are in those people with broad QRS and left bundle branch block morphology. It suggests that men and those that are younger perhaps benefit more from implantable cardioverted defibrillators mated with the CRT. And it does end with the suggestion that the guidelines need to address the issues of sex and age in determining who should get which device. Real-world data published this year, looking at 45,000 patients receiving a CRT device in France, suggests consistently lower mortality in those with CRTD, even after propensity matching, unless the patients are older and have a non-ischemic etiology, in which case there are no obvious benefits. So do we still need a randomized controlled trial? This is a challenge for the non-ischemic patients, I think. In a propensity-matched population from the States, with a mean age of 77 years, there was no overall difference in outcomes, although the costs were lower for those people implanted with a CRTP. In contrast, SWEDE-HF, where the focus was mainly on ICD, and the population 10 years younger, with propensity matching, there was a consistently lower mortality for those receiving ICDs. However, SWEDE-HF also showed us something else, namely that only 10% of the eligible population are being implanted. So perhaps some of the discussions we have around device therapy are a bit too focused. And our major question should be, why are we implanting so few, even in well-developed healthcare systems? Long-term data from the reverse study, which is now quite old and I alluded to at the start of the talk, suggests that there is increased survival in those with CRT of almost 2 years, even in people who have mild symptoms. So what we see with CRT and what we're increasingly recognizing is that although it is a great treatment for symptoms, people whose symptoms don't improve, so for example, those people who have mild symptoms at baseline, like the reverse population, or people who have a stabilization of their symptoms, are having a disease modification response, which doesn't always make them feel better, but stops them getting worse. Now, Reverse did show us that CRTD versus CRTP was associated with an increased survival. One of the other questions that is often raised is, do we need CRT in the post-paradigm world? In other words, if we gave everybody Entresto, would their LV function improve to the extent that CRT is no longer necessary? Well, that's an interesting question, because sacubitril valsartan does lead to dose-related beneficial remodeling, with a mean ejection fraction improvement of around 7.5%. But remember, what we haven't looked at in any of the sacubitril valsartan data yet is patients with left bundle branch block. And here are just 3 data sets showing that people with left bundle branch block have a markedly lower response in terms of remodeling to optimal medical therapy than those with narrow QRS complexes. In other words, it is highly unlikely that even with Entresto and its very important beneficial remodeling outcomes, that we're going to be able to forget about CRT and simply focus on optimal medical therapy. Quite the contrast. If you ask me, the greatest results will be a combination of optimal medical therapy followed by CRT, followed by further optimization based upon the hemodynamic benefits that CRT bring that allow you to take optimization even further. To go back a few steps to what we discussed with Reverse, there is also the outstanding question of response. And this is now at last receiving some attention. For a long time, people who didn't get improvements in their symptoms were classed as non-responders. And of course, we don't demand this of medical therapy. We don't stop the beta blocker or the ACE inhibitor if the patient doesn't feel better. We continue them because we believe the patient is getting some disease-modifying benefit from this, and perhaps the condition is deteriorating more slowly. And it does seem silly that we have a different threshold or a different guideline to follow for device therapy. So what exactly is a non-responder in device therapy? Well, we currently accept the fact that patients with ischemic heart disease, with multiple comorbidities, who are older, respond less well to CRT. But is this actually the case? Or is it just that their underlying disease process is more rapid and that CRT is slowing it down rather than transforming them into somebody 10 years younger than they are? Because no matter what we do, ladies and gentlemen, patients will continue to have symptoms. Even with optimal medical therapy, symptoms persist. So perhaps we should change our targets, not to improving patients, but to stabilizing the disease. Because even with optimal medical therapy and CRT, deterioration for many patients will continue. But these are not non-responders. Here you see a simplistic graph of what happens to a patient with heart failure. On the y-axis, any variable you choose to think about. This is what we want. We want the patient to come back happy, run into the room, saying, "Thank you very much. I now feel like I did when I was 30. Of course, that almost never happens. This is much more common. These 2 patients are also responders to therapy. The first hasn't got any worse, hasn't got any better, but traditionally has always been labeled as a non-responder. In fact, the third, who continues to deteriorate, is also a non-responder, but actually has done really very well. Their deterioration is slower and they've lived longer with the disease. So we need to completely redefine the way we label patients with heart failure, particularly those receiving CRT. And one of the situations that this particularly falls down is LV reverse remodeling. We seem to base our concept of treatment results on LV reverse remodeling. And that's fine, because we know that LV reverse remodeling is important in terms of prognosis, but it doesn't relate to clinical response. On the other hand, patients favor symptom control. That's their priority. In an ideal world, what one would do is combine clinical endpoints with patient-related endpoints, including symptoms. And if you do this with the clinical composite score, looking at the reverse data, you find that those patients who did not deteriorate, but didn't fall into the classical responder group either, have the same prognosis as those who fall into the traditional responder group, those who felt better when they came back. So we need to start thinking about our definition, and one of the reasons it's important is because it changes our priorities of who we look at more closely and who we look at less closely. We also need to explore what happens to the non-implanted. So, for example, the red line here are people who worsened despite CRT, and yes, their prognosis is not as good as those who were unchanged or improved, but are they doing as badly as they would have done had they not got the device? And I think this is another important question. Does the device slow down deterioration? And even in those whose symptoms have deteriorated despite the device, is it still giving them some benefit? One of the other things that we're starting to learn over the last few years increasingly is the need to incorporate post-CRT management into a comprehensive clinic setup. We need to optimize the medication. We need to consider comorbidities. We need to consider anemia, for example. But in an optimization clinic where there is a holistic approach, we must also remember not to forget the responders. Those people that do come running into clinic should also have their CRT delivery optimized, because actually these might be the ones who benefit the most from careful tailoring of their programming and optimal medical therapy. In a post-CRT clinic, we tend to focus on the non-responders, but we should actually focus on everyone. So, ladies and gentlemen, CRT is a great treatment for heart failure. It is still required post-paradigm and post-Entresto. It is still underused. It's unclear why. Is it because of the non-responder myth? Is it because people are concerned about absolutely needing a CRT-D in all patients? Is it because people are worried about whether they can implant it? Do we need more training? The key is that CRT improves longevity and stabilizes symptoms. Many patients will benefit from additional defibrillator cover, but it's absolutely not mandatory if the healthcare service or the healthcare system that you work in cannot manage to mate a defibrillator to every CRT implant. And it is not a cure for heart failure. Optimal medical therapy is still needed following CRT, even in the remodeled, even in the responders. And I think we should lose the term response. I think we should aim for disease modification. If the patient doesn't get better, that doesn't mean that the patient has failed or that the physician has failed or the device has failed. And we should absolutely not withhold device and drug optimization from those that have responded. We should offer it to everybody. Thank you very much.
Thank you very much, Dr. Witte, and I'll hand over to Professor Lind in a second. There's a 5-second delay, so we just have to be patient in the question and answer session. But if I can just start with one question, Klaus. Lots of interesting ideas there, and also can I encourage our viewers to send in questions too. But left bundle branch block, do you think if we call that left bundle branch blockopathy, we would then get more patients having CRT? And do you think biologically it's a different condition that does require electrical therapy?
Thanks very much, Martin. It's great to be here, and Cecilia, to see you there is also lovely. I agree with you, Martin. I think left bundle branch block is, in a large proportion of cases, a great contributor to the left ventricular dysfunction, particularly in the non-ischemic patients. And if we made more of it, it's entirely possible that we would push the thresholds for CRT downwards. And let's not beat about the bush here. The greatest problem in device therapy in Europe, even in wealthier parts of Europe, is not this discussion around CRTP or CRTD. It's just that we're not doing enough CRT. We're still underutilizing these devices in our patients. And I alluded to it in the talk. There are a number of potential reasons. And again, we have to face the facts that some of them are related to cost and the belief that one must always include a defibrillator. There are times when a defibrillator might be better than a CRTP, but not always. I agree with you though, Martin. We should consider left ventricular dysfunction in the presence of left bundle branch block a somewhat different disease.
Thank you. And I was going to hand over to Cecilia at this point, but I think we've just lost the connection. So I will wait for her picture to reappear. So, Klaus, there's some questions coming in here. Your comment on older patients and those with non-ischemic disease, where I presume, of course, that other causes of death might start to predominate. Were you really suggesting that people over the age of 80 with dilated cardiomyopathy shouldn't be considered for this?
No, Martin. I think it's always a personalized decision. There is absolutely no easy. It's absolutely impossible to make it a blanket decision around non-ischemic or age. I think you're absolutely right there. There are lots of people aged 65 with multiple comorbidities in whom a CRTD might be considered inappropriate, whereas there are some very fit 85-year-olds. So absolutely not. And of course, the patient must always be included in the decision with the appropriate information around competing morbidity and mortality risks. So the patient is a key, and their care is a key person to involve in the discussion. And the same thing is true, of course, for non-ischemic cardiomyopathy. If you're a young person with a non-ischemic cardiomyopathy, your risk of sudden death over the lifetime of you and your disease is actually not insignificant. So it is absolutely not a binary discussion. It's absolutely not a binary decision.
Thank you. I'm going to hand over, I think, to Professor Lind. So 5-second delay, and then Cecilia will take over. Cecilia.
Yeah. Thank you, Martin. I'm going to dwell on left bundle branch blocks, contributor even explaining the heart failure condition. Then perhaps start the drugs earlier. We should start the CRT earlier and delay the drugs, or doing both at the same time. Did you think about that? You showed 3 different studies saying that there is less reversal modeling by drugs with the drugs. What do you say?
So, Cecilia, it's a great question. I agree entirely. One of my major difficulties with the current guidelines is that they are very linear. And I think we're going to need to get a little bit cleverer and a little bit more holistic around the way they're designed. If we now know that even with Entresto, remodeling is less in patients with left bundle branch block, then the chances that somebody with an ejection fraction of 25% gets an ejection fraction of 35% if they have a QRS duration of 155 milliseconds suggests that rather than waiting some more and then optimizing some more, maybe one should have a parallel pathway for a lot of these patients where one combines, as the doses and the drugs are being optimized, device therapy much earlier on. And looking at our data from Leeds, it's clear that not only do but with a linear pathway, some patients fall by the wayside. In other words, they get lost to follow-up. And of course, some patients will have a sudden cardiac death while they're waiting for their drugs to be optimized. So if you ask me, I think if you've got left bundle branch block with a QRS duration of more than 150 milliseconds, there should be a combined process of optimizing the drugs and the devices at the same time.
Yeah, there's a further implication of that, and that is one good chance for any patients to get therapy is to be hospitalized. So why not do everything once we have our patients in the ward?
I agree completely. Of course, ideally, I'd like the patients not to be hospitalized and to do it in the ambulatory clinic. But of course, when they're hospitalized, we actually take the guidelines out of it and we do everything at once, don't we? So the fact that we're doing that means that we actually believe a parallel approach is better. So I agree with you. I think once you're hospitalized, you get on and do everything. But in the ambulatory clinic, I think we need to change our approach also.
So thanks very much, Dr. Witte, Professor Lind. I'm afraid we have to go on now to the final talk in the symposium, and a very interesting technology. It's changed a lot over the years. So great pleasure to introduce Lauren Topps, who's going to talk to us about left ventricular assist device technology. Thank you.
Good afternoon. My name is Lauren Topps, and first of all, I'd like to thank the organizing committee for inviting me to this session on device therapy in heart failure. My talk will be on left ventricular assist devices. For this presentation, I have the following disclosure. It is well known that the clinical course of heart failure is characterized by frequent hospitalizations for decompensated heart failure, and along its course, we need to intensify treatment from medical therapy to electrical or valvular interventions, and even mechanical circulatory support or heart transplantation. From many randomized trials, we know that we can rescue patients with defibrillators. We can improve prognosis with cardiac resynchronization therapy and even with percutaneous valvular interventions. However, we have to remember that despite improvement in survival with various interventions, heart failure eventually will progress. When heart failure progresses and begets advanced heart failure, we have different treatment options. For short-term management, we can use diuretics to treat congestion. We can use inotropes or even short-term mechanical circulatory support in cardiogenic shock. For long-term management, we can use conventional cardiac surgery, and heart transplantation remains the gold standard with the best long-term outcome. However, there's a huge shortage in organ donors, and the number of patients on the waiting list is still increasing. Therefore, there's an urgent need for alternatives for heart transplantation. And in the recent years, left ventricular assist devices have become a valid alternative for transplantation. When talking about numbers, in the US, there's about 7 million patients with heart failure, 3.5 million patients with systolic heart failure, and about 350,000 patients with advanced heart failure, New York Heart Association class 3 or 4. But only about 4,000 VATs are implanted each year. In my opinion, there's a huge underutilization of this important therapy. In the current ESC guidelines, long-term mechanical circulatory support with the use of LVADs have a 2A indication as a bridge to transplant for patients eligible for transplant in order to improve symptoms, reduce the risk of heart failure hospitalization and premature death, and as destination therapy in patients who are not eligible for transplant. In addition, it can be used as a bridge to decision. This is an example of a third-generation left ventricular assist device. It is a centrifugal pump that uses hydromagnetic levitation. It is easy to implant and it's placed intrapericardially, as shown in the diagram. It provides continuous flow. It has been demonstrated that third-generation LVADs have improved event-free survival, free from disabling stroke or reoperation, as compared to second-generation axial flow pumps. And more recently, the Lateral trial demonstrated even improved survival with 87% event-free survival at 2 years. Although these studies demonstrate that LVAD therapy is safe and improves prognosis, it still has its drawbacks. So how can we optimize the clinical benefit from left ventricular assist devices? For that, several issues need to be addressed. First, there's timely referral of advanced heart failure patients. Second, we need careful screening of potential candidates. Third, new surgical techniques may improve prognosis. And finally, we need to face the challenges during follow-up. We have to realize that timing of referral of patients and implantation of left ventricular assist devices is a difficult process. When VADs are implanted too early, patients may be too good to benefit from the therapy and are exposed to the risk of it, while when patients are referred too late, they may be too sick to benefit from the therapy. Therefore, it's essential to find the optimal moment of implantation. But what is the right time to refer a patient? Again, this is the typical clinical course of a heart failure patient. From our experience in the past, other centers refer their patients in this point in time, whereas, in our opinion, this is the optimal moment of implantation. It is important to realize that when patients transition into advanced heart failure, they should be referred to a tertiary heart failure center for advanced treatment options. The next question is, what is advanced heart failure and how can we recognize it? This position paper of the HFA gives a clear definition of advanced heart failure. All the following criteria must be present despite optimal guideline-directed treatments. Severe and persistent symptoms. Severe cardiac dysfunction should be present. Episodes of pulmonary or systemic congestion. And finally, severe impairment of exercise capacity. This is a nice, clear definition. However, it may be difficult to recognize these patients in daily clinical practice. And for that, this acronym may be very helpful to recognize advanced heart failure patients in your daily clinical practice. It is called I need help. The I from inotropes. The N from New York Heart Association class 304, or persistent high natriuretic peptides. The E of end organ dysfunction or low ejection fraction. The D from defibrillator shocks, when patients experience appropriate ICD shocks. The H of hospitalization. The E of edema or escalating diuretics. The L from low blood pressure. And the P of prognostic medication, for example, when you're not able to uptitrate medication or even need to decrease it because of progression of heart failure. These are all clinical clues that your patient is transitioning into advanced heart failure and may need more advanced treatment options. It is important to realize that not only patients who are admitted can be referred for advanced heart failure treatment options, but also ambulatory patients can have advanced heart failure and may be referred for screening. In fact, early referral enables better patient education and decision-making regarding LVADs on survival, functional capacity, and adverse events. The roadmap study was a non-randomized study between LVADs versus optimal medical therapy in 200 ambulatory patients with New York Heart Association class 3B or 4 with a recent hospitalization and severely limited exercise capacity. The composite endpoint was survival on original therapy with an improvement of more than 75 meters at 6-minute walking distance. And as you can see, the event-free survival of the LVAD patients depicted in the green line was significantly better compared with optimal medical therapy. In this sub-analysis, the benefit was clearly demonstrated in Intermex level 4 patients, whereas this was less clear in the less sick patients with Intermex levels 5 to 7. In addition, we have to realize that the superior survival and functional status compared with optimal medical therapy comes with a trade-off of increased adverse events and hospitalizations in the LVAD patients. Next point I'd like to touch upon is the careful screening of potential candidates, because not all patients that are referred for LVAD eventually get one. In our center, we have a dedicated screening protocol for advanced heart failure patients who are referred for LVAD therapy. We are a non-transplant center, so we only do LVAD as destination therapy. And when patients are referred, we screen them according to this protocol. We check if patients have optimal medical therapy. We check if there is an indication for revascularization. Are there any arrhythmias or ablational options? Is there an indication for CRT or other surgical or percutaneous valvular interventions? And if not, patients may be eligible for destination therapy. And this screening comprises several dedicated specialities. Not only cardiologists and cardiac surgeons are involved, but also anesthesiologists, intensive care, physiotherapists, and other colleagues from different specializations. And we consider the general physical condition, cardiac anatomy and function, comorbidity, infectious disease, expected perioperative problems, but also psychological and social aspects are considered. New surgical techniques may also help us in maximizing the clinical benefit from left ventricular assist devices. The Lateral trial investigated a new lateral thoracotomy implant approach in 144 patients who received an HVAD as a bridge to transplantation. It was a non-randomized, multi-center study that compared patient outcome with the data from the ADVANCE and the INTERMAX registry. The primary endpoints was a composite of 6-month free survival of disabling stroke while alive on an original device. And the secondary endpoints included length of initial hospital stay. As earlier demonstrated, the event-free survival at 2 years was 87%. Importantly, the length of hospital stay was significantly reduced as compared to the ADVANCE and INTERMAX data. And finally, bleeding requiring reoperation was significantly lower at 30 days and even 6 months and 1 year follow-up compared to the other data, and there was a low incidence of acute RV failure requiring RVAD. Therefore, new surgical techniques may have impact on clinical outcome after LVAD implantation. Finally, challenges during follow-up need to be addressed to maximize the clinical benefit from left ventricular assist devices. Several adverse events can be experienced while on VAD therapy, and the most important include, for example, bleeding, mainly gastrointestinal bleedings, neurologic events, up to 20% in INTERMAX registry, right ventricular failure, both acute and chronic, and the reported incidents are different depending on the definition. Device-related infections, up to 40% in the first year, according to INTERMAX registry, and device malfunction caused by thrombosis, up to 10%. And finally, aortic regurgitation. When we look at the INTERMAX registry, at 12 months, about 70% of the patients have at least one major complication experienced. In order to address these adverse events, again, integrated care and a team approach is needed to support our patients with ventricular assist devices. So to summarize, when we want to maximize the clinical benefit from left ventricular assist devices, we have to consider timely referral of advanced heart failure patients. We have to recognize when patients transition into advanced heart failure using the acronym of I need help. Careful screening of potential candidates is very important. And again, VAD care is a team effort. New surgical techniques may help us to improve both morbidity and mortality after VAD implantation. And finally, challenges during follow-up need to be faced, and we need to try to minimize device-related events. Thank you for your attention, and I'm happy to take your questions afterwards.
Thank you very much, Dr. Tops. Very interesting advances in this technology. Questions from one of our viewers. How do you select patients for lateral thoracotomy versus median sternotomy? Is there a clear way of deciding?
That's a great question. And actually, I'm one of the cardiologists, not of one of the cardiothoracic surgeons, but so they have may have a different opinion about that. But typically, patients who already had a previous operation are good candidates to have a lateral thoracotomy. or patients who have somewhat higher risk of RV failure after operation. Yeah.
Thank you. And I'll hand over to Dr. Lind in a second with the 5-second delay. But before then, another question's come in. The strokes that occur in these patients with third-generation technology and better understanding of clotting, how devastating are these strokes? Are these TIAs or very minor, or do they tend to be quite devastating and life-changing?
There's a wide range, actually, with third-generation pumps, ranging indeed from TIAs to devastating strokes. So that's it's the broad spectrum, let's say. Yeah.
Thank you. And Professor Lind, with the 5-second delay.
Yeah, thank you very much for your presentation. I too wanted to focus on the adverse events because I do understand that the major problem is finding the patients. But when we find the patients, we also have to make a good job of convincing them that the benefits are going to be much larger than the adverse events. So how do you deal with that in your personal clinic?
That's an excellent question, and indeed it's still one of the Achilles heels of the therapy, I think, to select the right patient. And as I've shown in my presentation, we have a multidisciplinary team ready for the patient to assess if it's a good candidate. And not only anatomical issues should be addressed, such as valvular disease or LV thrombus, etc., but also more psychological aspects, if the patient is able to handle the therapy, let's say, and also the risk of complications such as infections, etc., should be addressed before we implant the LVAD, of course. So I think the key issue is the team approach.
Thank you very much. And I think we've now not got time.
And then, of course, you also emphasize.
Sorry about the technical issues we're having. So thank you very much, Dr. Tops, a very important topic. And I love your acronym, I Need Help. I think all cardiologists can remember that. So thank you for